All right, thank you very much, and thanks for the invitation to be at this conference, and thank you for giving me the con position. I'm really not thankful for that one. Okay, so we'll jump into this. We can move forward. Right, so we learn in U.S. politics the first thing you should do in any sort of debate is destroy your adversary on the basis of their personality, if possible. I can't do that, obviously, here. So what we'll talk about this was Dr. Kodali, when he began to prepare for this, he was sort of fresh and ready, and as he struggled to find any data, things transformed a little bit. My goal with this debate is really not to turn him into this sort of sage wizard who knows it all. That's what I'm trying to achieve. So patient selection, and in fact we agree about a lot. Really what we're going to end with is a slightly different conclusion, but there's a lot of overlap. So when you approach the patient selection for TEER, symptomatic severe, yes, really not the moderate to severe, but you're really looking for severe. Is MR the primary lesion? If it's secondary MR, are they on GDMT, including CRT? Is it atrial FMR? And then, these are the discussions. And then we've already seen sort of how we get into the anatomic selection, which is the second level of discussion. But really for this discussion, really if you look in the orange and you have very wide jets involving the whole coaptation zone, those are some of the challenges when you get into the very sick secondary MR cases. We've also heard, and I'll amplify it, that the hemodynamics that you achieve definitely matter. This is sort of a similar study showing it differently, but basically if you achieve MR reduction of more than 3 grades, if you have an important impact on the S wave of the pulmonary vein, the VTI of that, and you achieve an LA pressure that's low, the more of that you achieve, the better the patients do. No surprise. So the residual MR you leave behind does matter, and it matters also in secondary MR. So leaving behind less MR is clearly a goal. So the co-op study, amazingly, 6 years ago, it's hard to believe it's been that long. Clearly there's data, important data. This data has driven the guideline changes. You saw this already. So for secondary MR, these are the criteria. And again, emphasizing what you saw down here, really we have the data for the EFs of 20 to 50%, the ventricles that aren't enormous, so less than 70 millimeters diameter, and a PA pressure that's reasonable. So when you meet all those criteria, we have a guideline recommendation for TEER. But let's look at a particular patient. So this is somebody who was treated with TEER, a bad ventricle, end-to-side coaptation, significant MR, got one clip down the middle, which is not uncommonly performed, and a little bit of medial residual MR, a pretty typical outcome from an M-TEER case. And was this the right choice? Should we, in this case, have gone with the TMVR? Potentially. So this is really what we're trying to answer. We also saw that the co-op now recently has 5-year data. I cannot argue with this data. It's very impressive data, and we've heard this already, an important difference in all major things. So the events, all events really, hospitalization, and in fact mortality, death from any cause. Dr. Stone's on the panel. I'm sure we can go into this for the entire day, but this is incontrovertible, the benefit we have in these selected patients. We also know that atrial FMR is increasingly being described and recognized. And there has been some discussion that this is maybe a subset of secondary MR that's more difficult to treat. You don't have necessarily the coaptation reserve that you might require for an edge-to-edge repair. And we have recent data in this particular study that just sort of looked at that and said, well, let's look at secondary MR with preserved EF, secondary MR with impaired EF, and look at the two. And these are the sort of the summary conclusions at M-TEER for secondary MR with preserved EF, so AKA atrial functional MR. The technical success was really no different, which was an important message. The clinical outcomes were not different in terms of those with reduced EF, and the mortality and hospitalization and the amount of residual MR were not different. So perhaps atrial FMR is not as scary for the M-TEER concept as some of us were led to believe initially. But this is sort of where we get into the debate issue, is how do we choose the patients based on ventricular function, particularly for secondary MR? So this is a spectrum of different LVs. On the far left, we have the very dilated EF, a very dilated ventricle. EF's very low, global longitudinal strain is low. On the right side of the spectrum is sort of maybe this strategically important infarct. It just hits the papillary muscle wall region. EF might be near normal, might be normal sized. It's still secondary MR, and global longitudinal strain may even be within a normal range. So very different spectrum. So all this to highlight that secondary MR isn't one phenotype. It's a collection of a huge spectrum of phenotypes. And I think that's really the key in this patient selection discussion. So over here on the far right, the MR correction might be beneficial. On the far left, the transplant, LVAD, hospice might be the right strategy. The concept is somewhere down the middle, there's a line of helpful and futility. But where is the line? And when you've got a patient in front of you, this is the clinical decision making is do we do anything? And then how do we decide what we do? So Vinny Badwar has this really interesting publication recently. And I like this one because it sort of emphasizes that with cases ready, I see now. Okay, so I'll go quickly unless somebody tells me otherwise. Similar idea, emphasizing that there's a spectrum of LV dysfunction. It goes through actually creating grades. So grade 1, 2, 3, 4 for SMR. And in those, not only is the EF part of this grading system, but also the magnitude of the annular dilation and the degree of tethering of the LV and the leaflets. So really thinking about grade 4. And there's some suggestion that how we treat with transcatheter really should be impacted by the grade 1, 2, 3, or 4 designation of the pathoanatomy of the MR. So transseptal TMVR is really where we are. I think we've left the days by and large of transapical. We have this interesting aging landscape. Most of these devices are now no longer even in use. This was a review from almost 10 years ago. So it's incredible how these devices have changed, the approach has changed, many have fallen away, they haven't worked, and we're still struggling to get to commercial TMVR. So a different case, this is a clear severe secondary MR. This is sort of the outcome, easily highlighting that there is no residual MR, and we saw that already. It's very effective at not giving any residual MR. So in that point, it probably gets a small win. One of the challenges are the hemodynamic impact, and we heard this already, in the hemodynamics of the LV. So on the left, and focus maybe on the top left, look at the annular motion in this secondary case. Post-TMVR, you have this annular paralysis. So you've basically stuck a Coke can in the annulus, and it's not going to move the same. So if the annulus is already not moving at all in a severe LV, that may not matter. But if you were to do that to an LV that is otherwise not as bad, you are perhaps impacting things. So we have to sort of use our multimodality imaging to sort that out. When I first started this sort of prep, with TMVR for secondary MR, that's a data-free zone. This is going to be easy. I have nothing to say. But in fact, there is data. So some of the data was from the CHOICE registry. So this is transcatheter mitral valve replacement versus medical therapy. So they did a very interesting thing. They basically combined registry data on TMVR and compared it to the medical arm of the COAP study. And when they did a propensity analysis and matching, we get down to about 97 patients who had very similar ages, EROA, LVEF, and LV, and diastolic dimension. So not randomized, but an interesting comparison of two strategies, medical therapy versus TMVR. And in that analysis, for selected patients who had secondary MR, if you used TMVR devices that were specifically built for the mitral position, it represented a safe and effective alternative, providing symptomatic improvement and less frequent heart failure hospitalizations than the medical therapy alone. So some data that is better than medical therapy. An expansion of that then was a similar comparison from using now M-tier derived from a European registry, and again comparing it to this CHOICE MI registry of TMVR. So not a head-to-head, but it's really asking the question, is M-tier better than TMVR for these secondary MR cases? Again, looking down here, what do we see? And oops, I'm sorry, go back here. There we are. Right. So there is some signal here that there isn't necessarily a mortality benefit, but it is not inferior. So, okay, well, we're getting closer to compelling data. But again, emphasizing this outcome on MR reduction. Just said differently, and you've already heard this, and really one of the prettiest graphics I've seen in a while. On the TMVR on the left, if you look at where you started, the vast majority had 4+ MR, a few had 3+. Almost everybody gets to none or 1+. So that is the hemodynamic outcome of TMVR. The M tier, a little more 3+ and 4+. But as we see clinically, you're left with 1+, 2+, occasionally 3+ and 4+. So the MR reduction is different. In summary, transcatheter therapy for SMR, the M tier, and this is where Dr. Kodali and I really agree on a lot of things. It's safe. Has a low screening rate. We all know these patients, and we can identify them almost on the transthoracic. They're easy to find. The MR reduction, but not elimination. You have very minimal impact on the annulus. It's a relatively quick implant these days. We have lots of randomized controlled data around safety and efficacy. But the question is, should we really be restricting this to sort of this grade 1, grade 2 LV dysfunction? The TMVR, safe-ish. We have bleeding. We have neo-LVOT concerns. This really impacts screening. We have a very high screening rate in some of these trials. It's 20-to-1 to find a patient you can actually treat. We have MR elimination. We have very rare PVL. You can expect annular paralysis. So if your annulus is dynamic and active at the beginning, maybe this is not the right therapy. You have a relatively long procedure time. We definitely need more randomized control data. And the supposition is that grade 3, grade 4 LV dysfunction, maybe that's where we should be restricting this. So back to Dr. Badwar's concept here, bringing back this notion that there is a cut point when M-tier is appropriate. There's probably a cut point when TMVR is appropriate. I think where we need to focus is, where is this? Is it 3 and 4? Is it 2.5? And that's where we need some data and probably a little help. So I don't know, I think this probably is Dr. Cordali, but I'll end there. Thanks very much.